All right, so let's talk a little bit. What is your thought when you hear labor, interpartum? What do you think right away? Contractions, right? We should have contractions, because without contractions, are we gonna have a baby? No, we are not. Okay, contractions. What about contractions? They should get more frequent as we progress through our dilatation, our effacement, and all of that. Okay. What else about contractions?
They hurt the girl.
They what?
They hurt.
They hurt, right? They hurt. Labor is not for everyone because it's painful, but with an epidural, that's the loveliness of medication, right? But yes, they hurt, okay? What else do you think of when you think labor? You hear someone is going into labor. Blood? Yeah, blood, right? Or lochia, right? Because you have that shedding. Definitely, you're going to have some blood loss. What else?
Dilating.
Dilating, right? So we have to go from a closed cervix to about this big of a cervix, okay? All right, what else about labor?
Pushing.
Pushing, right? And what can impact pushing? Strength, what else?
Contractions.
Contractions, what else?
If the mom's scared.
Psyche, oh, definitely psyche, right? Okay, all of that can impact it, okay? So what else do you think of? No one said it.
Water breaking.
Water breaking, rupture membranes, okay, yeah, which that usually means what?
That they're going.
You're gonna have a what soon? A baby, right? The ultimate outcome is, what's our ultimate outcome of a labor process?
Baby.
Healthy mom, healthy baby, right? That's the ultimate outcome. So how do we get from 0 to healthy mom, healthy baby? We're gonna talk about each step of the way. And most people think, oh, you just go in and you have a baby and it's a quick little process. It is not, okay? Lots of things impact it. All right, so we're gonna first talk about uncomplicated labor, uncomplicated birth, because that's the perfect world, right? We have to understand what the norms are to then understand what the abnormals are, okay? So we're gonna talk about a perfect world delivery, and then we're gonna talk about what can go wrong to impact it not be a perfect world delivery. We're gonna talk about pain management. So pain management is crucial with these patients. Why?
To relax. To deliver the baby.
Because you have to relax, right? So what are contractions? We're gonna talk. The squeezing, right? So the contractions are squeezing, and what's the purpose of the contractions? Not just to make mom have pain, what is the purpose of the contractions? Down, 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 right? That head is doing what on that cervix?
Oh, it's hitting it.
It's hitting it. Why is it hitting it? It's gonna help it to dilate, right? And so pain is crucial. So if you're having adequate contractions, but every time mom has a contraction, she tenses up like this because it's painful, what is happening?
She's not letting it.
You're counteracting it, right? You're not being able. So if they're doing that, definitely you want to have them have some pain management. I tell patients all the time, it does not go on the birth certificate if you got an epidural or not. It does not mean you're not a woman, right? Because again, we got to have that pain, okay? So I have had people say, I want to do it natural, and they come in and they're like, I want no pain meds, I want nothing, and they get to 3 centimeters and they're like, I need pain meds. And I'm like, okay, right? I've had patients who come in and say to me, don't let me ask for an epidural. Do not let me ask for one. I'm like, that is not my job. I will remind you what you told me when you were happy and not in active labor, but I'm not gonna do that to you, right? I have other patients who, this was actually me when I went in with my daughter. And I was like, I want an epidural. The minute I hit the door, I want to feel nothing. I just want to lay there. I had like the movie sensei, right? I'm just going to lay there like a princess, and I'm going to have this baby. And I ended up doing my daughter naturally with 0 medication. And so again, you go in with an expectation, you go in with a thought process, but nobody knows how their body's going to respond to that pain, okay? I said I wanted an epidural the minute I walked in the door, and I got there, and they said, we won't give it. It used to be we didn't give epidurals till they were 4 centimeters or more. And so they said, not till you're 4. And I was in pain, and I was crying because I was a baby. I was only 20 years old. And the nurse was very mean to me. I think I told you guys, I told her I was contracting. She didn't believe me. They put internals in, and it was like mountains, right? And so she says, if I give you, I was 4, I think, at that point. If If I give you an epidural, you're gonna end up in the OR, and you're gonna have a C-section, and that's major abdominal surgery. They're gonna cut through 7 layers of your stomach. Is that what you want at 20 years old? And I started crying again. I was a crier back then, not anymore. And I'm like, I don't want surgery. So I toughed it out, and then finally I broke down and I said to the nurse, I said, I don't care if I end up in the OR, give me the epidural. She checked me, she's like, you're complete. We don't need an epidural. Push this baby out. I pushed 6 times, my daughter came out naturally. So again, right, everyone has their experience, everyone has what they think, but pain plays a huge role. Fetal surveillance, we already touched upon. So fetal surveillance is the fetal heart rate. I'm gonna just hit on it a little bit, just for time purposes, because we already have an hour and a half of our day. That's why we went over it in lab or boot camp. So you have that PowerPoint to review, but you will need to know baseline and all of that. And then we're gonna talk about obstetric procedures and then complications of the labor. All right, so labor is actually a physiological event involving lots of different changes that occur gradually. You do have to have the uterine stretch. And why does the uterus need to stretch? It's already stretched, right? But we need what hormone to help with the ligaments?
Estrogen.
Estrogen and relaxin, right? We have that relaxin that's also going to help because again, we have to stretch. All right. Also, you have your oxytocin that plays a role. Because we have oxytocin in our brain, that's a hormone. What is oxytocin responsible for? Milk letdown and contractions, okay? So oxytocin is key. So if someone doesn't have enough oxytocin or their body is not ready to go into labor yet, because that does happen sometimes, we can give them Pitocin, which is the synthetic oxytocin, and that's IV that we give in small little increments. Remember, if she's still pregnant, what is that drug considered? And you cannot touch it. A critical drip, right? Pitocin is a critical drip when the baby is still in utero. Once baby's extrauterine, I don't care what you do with the Pitocin, flood them all you want. No, please do not. But again, you can titrate Pitocin after the baby's out. And the reason is very small parameters, okay? But again, we need this oxytocin in our body if it isn't produced naturally. And I will tell you, we have become a pharmacological world, right? You've noticed that. Everyone's pushing drugs on everyone all the time. My patient yesterday kept having panic attacks. She thought she was having a heart attack. They thought she was throwing a PE. They did CT scans. They did all this stuff. And it was simply anxiety. Right? It was just anxiety. Everything ruled out, which I'm glad they ran the gamut of tests, not really. But she was just having panic attacks, anxiety. So again, but we are a pharmacological world. And so we pretty much give, I want to say, I would love to look at the statistics. I'm estimating 85 to 90% of patients some type of Pitocin to initiate their labor. So that's a huge amount, right? And you would think the body would just naturally do it. But what happens is sometimes they have enough to get them started, but they don't have enough to maintain that contraction pattern. And what are we? Instant gratification society. We want fast results. We don't want to sit around and wait and let the process be the process, right? Because that's what happened in the old days, right? There was no synthetic form of medication to make you contract and have a baby faster, okay? But we do, we give quite a bit of oxytocin to initiate, and we'll talk more about that. You also have an increased release in your prostaglandins in your body. And what is a prostaglandin's purpose? Everyone has med cards that are due when? Tomorrow, right? And when you come to, where are we meeting at tomorrow? YREC, the Education Center across from YRMC. We're meeting at YREC in the computer room, okay? So what is a prostaglandin? Out of your meds, what would be a prostaglandin medication? Those are NSAIDs. They are, but the big one that we use is Cytotec, okay? Cytotec, and what does Cytotec do? So Cytotec is a prostaglandin that helps effacement. Effacement is the thinning of the cervix, okay? So again, there's certain criteria that you have to meet, but we hope they release enough prostaglandins to start effacing that cervix. If not, we can give the synthetic. Once again, what type of world are we? A pharmacological world, right? We can give some prostaglandins to help try to efface that cervix. Also, during this time, progesterone draws back. It goes away because your estrogen is increasing and your oxytocin is increasing. So progesterone's like, okay, I've played a role, I've maintained that pregnancy, I don't need to be as strong anymore. Let me withdraw and let estrogen and oxytocin and relaxin do their jobs, okay? All right. So labor is affected by the 5 Ps. They do have an additional 5 Ps that they just kind of came out with, and we'll talk a little bit about that. But your major 5 Ps are your passageway. That is your birth canal, and we're going to go through each of these individually. You have your passenger. Your passenger is your fetus and your placenta. You have your powers, your contractions. Then you have your position. What is the best position to have a baby? Whatever position they're comfortable in, which we'll talk about different types of positions. And then you have your psychological responses. Sometimes I think the psychological response is the biggest P of them all, because if mom is all over the place, we're not gonna have an effective labor process, okay? So we need to assess their psyche right away. What can impact their psychological response? First time mom.
Fear
Fear. Fear of what?
of having something come out of your vagina.
Having something come out of your vagina, especially when we show them our little dilatation. We're like, your cervix has to get this big where my fingers can't even touch it anymore, right? Fear of doing vag exams. A lot of patients are fearful because in the office, what happens? Usually, what type of gender are OB doctors?
Males.
Males. Are males' fingers larger than females' fingers?
Yes.
Usually, yes. Also, do males have a vagina?
No.
It's not a trick question. Everyone should say no to that, right? So men go in there and they're aggressive and doing all this, so they're fearful of that happening constantly when they're in labor, okay? We just had a patient yesterday who she refused all vag exams. And we're like, how do we know when you're going to need medication, when you're gonna deliver, different things like that. So it's a lot of education, right? But their psyche plays a major role. Also their partner. Can a partner be positive or negative impactful during this process? Yes, they can, right? Why would they be positive? That's an easier one. Supportive, reassuring, right? How can they be negative?
Not being there.
Abuse, not being there. Hey, stop, I want to watch the Pacers game, right? I can't do this right now. Yes, you have a lot of those. They want to watch the football games, the basketball games, not being supportive. So again, we have to assess all this. So I remember I told you when we first started, if you like psychosocial, this is your place to be because there's a lot of psychosocial drama going on. All right, your additional 5 Ps for the process: philosophy, partner, patience, natural timing, the patient, how prepared are they, and then pain management, okay? All right, who knew that there was 4 different size and types of pelvises that you can have, right? So, who in here knows that they have a gynecoid pelvis? Nobody usually, right? They don't tell you that. But the reason that this is so important is this is the passage. So this is the way that the baby has to come out, okay? When you look at these different pelvises, you have your gynecoid, you have your android, you have your anthropoid, and your palpitoid, okay? What do you think is the most favorable pelvis for a baby to come out?
D.
Gynecoid?
Why the gynecoid? It's shaped like a head, right? And look at those childbearing hips on that gynecoid, right? Nice hips, and you have that round. If you look at the platypultoid, that one is more oval shaped. Can you see a head fitting out of that? Probably not as favorable. So the gynecoid pelvis is considered the true female pelvis. However, it only is 40% of women. Okay, 40% of women have the gynecoid pelvis. So right away, what does that tell you when we talk about complicated labors? Anything other than a gynecoid, we're gonna probably have some complications, okay? So again, that is the most favorable vaginal pelvis and the most optimal. And it is also very less common in men, right? Why? How many men have you seen, other than the guts, have childbearing hips, nice wide hips? No, what do men usually stature? Straight, right? So I always laugh because the scrubs that we have, the OR scrubs that we have, they're made for men. Men probably make them, they're made for men. So they don't fit the hips. You either have to wear them low or you gotta go a size up because it's not shaped for women, right? Most women have a shape around their hip area where men don't. How many men have you seen which is flat butts, right? Flat butts, where girls, what do we have usually? A nice juicy booty, right? And so we're just differently proportioned and differently shaped, okay? So again, gynecoid is the most favorable, usually in women, less common in men. All right, then we have our anthropoid, we'll go in order. Our B, our android. So this pelvis is actually considered the male-shaped pelvis. It occurs in about 20% of women. The prognosis of having a vaginal birth is poor, which leads to what? A C-section. Then you have your anthropoid. This one is common in men and most common in non-Caucasian women. So how interesting is it that different ethnicities tend to have different pelvises as well? This one, it is more favorable to vaginal deliveries, but you are going to have what we call dystocia, or some type of complication going on. But again, it can have vaginal delivery. So A and C usually are pretty good. Your D is also very high fail rate for vaginal delivery, and you're gonna end up probably in a C-section, okay? So when this pelvis is getting ready to have this baby go down in the birth canal and all that, what needs to happen? What hormones? Estrogen and relaxin are going to do what? They're going to relax the ligaments of the pelvis to allow it to expand, to allow a baby to have the passageway, okay? All right. Any questions on the passageway? Again, hormones play a role, pelvis shape and size play a role. If a person, so let's say, we don't know what pelvis they have, okay? But we're having a dystocia. Dystocia, you're gonna see, there's like 3 slides of what can be a dystocia. It's any complication that can occur to the passage or the passageway, it powers any of that, okay? And baby just does not come in the birth canal. That usually tells us it's a pelvis issue. If they need a C-section, they're probably gonna need every delivery a C-section, okay? Because if that baby doesn't come down in that pelvis is not favorable for a vaginal delivery, okay? So again, when we do C-sections, we always wanna know what was the indication? Why did they have it? Because if it's truly a pelvis issue, no other baby's gonna fit in that pelvis. All right.
So you don't know until you actually just start to.
Yes, ma'am. Yes, ma'am. Yeah, you don't know. They don't do ultrasounds or x-rays and they're like, you have a very favorable pelvis to have a vaginal delivery. No, usually what happens is there's a dystocia. And if it's a pelvis issue, I will tell you, 99, because I never say 100%, is usually the baby can't get past 0 station. The baby can never get engaged in that pelvis, and we're gonna talk about stations in a little bit. Babies just in those floating numbers because it can't engage because the pelvis isn't shaped properly. So if it's a failure to descend or anything like that, that tells me it's a pelvis issue, it's a passageway issue, and they can't have any vaginal births after that. Yeah, it could be a macrosomic baby, so again, that can play a role, but usually, if it doesn't get past 0, at even 0 station, and it's stuck without engagement, then that tells me it's passage. Does that make a little bit more sense? Yeah, all right, so our passenger, this consists of our fetus and our placenta, okay? So the fetal head, so why is the fetal head so important?
It's supposed to come out first?
It should in a vaginal delivery, yes. So this head is amazing, and remember when we talked about the newborn assessment, what are we gonna assess? We're gonna assess those sutures, right? And so what these sutures and fontanelles are the purpose for is to have molding happen. What is molding? We talked a little bit about that cone head, right? That baby's head has to mold to get into that birth canal and come out of the birth canal, okay? So molding is perfectly normal. And again, this is why they have these fontanelles and the sutures to allow for this head to mold. Do we have sutures and fontanelles? Our fontanelles should have been closed a long time ago because we don't need to do anything with our head, right? So again, super, super important. So with molding, what's happening is these sutures are overriding each other to be able to be compressed to get out of that birth canal, okay? All right. Again, we have the fontanelles. What are the fontanelles? They're gaps within the sutures, so you can see the anterior fontanelle and the posterior. The posterior is the triangle, and the anterior is like a diamond, kinda. And so those are the openings that allow the sutures to mold and go back, okay? Presentation is, and I always laugh if you see close, my little baby on there is so jaundiced. He's like yellow, glowing. But presentation cephalic. So we want them to be cephalic, vertex. What does that mean? Head down, okay? Head down is the key for vaginal delivery. They can also be breech or shoulder. Again, those are gonna be your cesarean deliveries. Again, it just shows you. All right, also with our passengers, so we want to know what is the presenting part. Is it the head? If it's the head, that's great. Then we want to figure out what is the fetal position, okay? The position of the fetus plays a very important role. So the fetal position is the relationship of the presenting part of the fetal body to a specific quadrant. Now, there's a couple pictures that you're going to see. You are not going to be asked, are they LOA, ROA, but you have to know what that means, and you have to know what we do and how this baby is going to be affected, okay? So again, you have right, left, posterior, anterior. LOA, or left occiput anterior, is the most common position, the most favored position that we want, okay? ROA is the second most common. That tells us that this baby is in the fetal position, in there, how it should be, okay? If they are ROP or LOP, that is when they are sunny side up, is what I call it. So the fetal face should be against the spine or turned towards the spine. If it's the opposite way and it's sunny side up, looking up into the world, because they should come out looking down and rotate, okay? That's how they should come out. Looking down to the ground, and as their head comes out, you'll see when you see a vaginal delivery, they'll do a nice little rotation, and then we can pop the shoulders out, okay? So if they are sunny side up, that means that their skull is where? Against the spine. So it's looking up. So what do you think is going to happen with their contractions? If you have the spine and this head is doing this to the spine,
You have it all on your back.
you're going to have all back labor. Yep. So if we have back labor, we know that this baby is looking the wrong way, and this baby, we need to figure out how to rotate. That is why we change positions. We're trying to move mom to rotate that baby, hopefully. So if they're having all back labor, so we do have rails around the unit, and they're there specific for a purpose. I like to tell my moms if they're having back labor, when they have a contraction, to lean over the rail and to rock their hips back and forth, because what does that do? It pulls the head off the spine because you're leaning forward and gravity is going to take its course to relieve that back pain, okay? If you have a partner, greatest thing to do is teach your partner. Your partner is your helper, right? I put my partners to work all the time. I'm like, come on, Dad, I got a job for you. Every time she has a contraction, they can put counter pressure on that spine to try and help take that head, because what's the hardest part? The head. Would you prefer a face hitting your spine or the back of a head hitting your spine, right? And so they can take counter pressure to relieve that pressure in the back. Back labor is horrible. It's a slower labor. They're gonna take longer to deliver because, again, the position of that fetus. Alright, so this just gives you a little picture again of what is happening. You have your ROP, your LOA, your, all of that, what's happening. So again, if you're anterior, best position you want them in, that means that the fetal face is facing what? The spine. If you have posterior, that's not good, and what are you gonna have? Back labor, okay? Because that head is hitting that spine. You also have your fetal lie, okay? And what the fetal lie is it longitudinal or is it transverse? These are the only two that you have. Oblique is only them getting into either longitudinal or transverse, okay? Oblique is not a lie, that's like a in-between. What are they doing? Are they gonna be longitudinal, which is up and down? Are they gonna be transverse, which is this way? Which way can we do a vaginal delivery?
Longitude.
Longitudinal with what presenting part?
The head.
The head, okay? So phallic, vertex, longitudinal is the only one you want. Can you do a vaginal delivery with a transverse baby? It's not gonna come out, okay? So it's not gonna come out vaginally if it's laying in that lie. So would we even try to induce a transverse baby? No. We would know they automatically are a candidate for what type of delivery?
C-section.
C-section.
Do they turn them? Do they try to turn them?
So yes, we have that on obstetrical procedures, but yes, they do try to do versions where they try and turn them. We just had a patient, wasn't yesterday, it was my last shift, that a provider did a version at 36 weeks and she came in 2 days later, the baby had passed. She blames the provider for killing her baby. She didn't want him anywhere near her with this pregnancy. She was extremely anxious because she was scared she was gonna lose this one too. So she refused to be taken off the monitor. Until she delivered, she refused to leave the hospital. I'm like, I didn't know you could do that. She was like, I'm not leaving. I'm 36 weeks. My baby died last time at 36 weeks. I'm here until I deliver. That doctor can never walk in. It was kind of an ethical, yeah. Yes, they can. There are complications, which we'll talk about. All right, so not only do you have, again, your fetal presentation, now you want to see what is this face like, okay? So we have longitudinal, and now we have to see, is it face presentation? So when I do a vag exam, I'm going to use my little fingers here, right? When I do a vag exam, I need to feel, what am I feeling? What do you think I want to feel? What is the fetal position? You want to feel the sutures, right? You want to feel, because how should baby be? Just like this, tough, nice and tight. If the baby's coming down asynclitically or not appropriate, then you might go in and feel the brow presentation or even the face. What do you think the face is? Would that be a hard delivery?
Yeah.
Yeah, because again, that you have that extension, right? We don't want that. What do we want? We want good flexion, right? We want them nice and tight in that fetal position, okay? Vertex is the best position we can have. Vertex, cephalic, that's what we want. You also can have breech presentation, which we'll talk about in a second. And then you have your shoulder. What do you think? Can you get that baby out with the shoulder? There's no way, because that's more what type of lie? Transverse, right? It's more of a transverse lie, so not a longitudinal. All right, so these are different variations of breech presentation. So frank breech is A. This is where their butt is stuck in there, but their legs didn't get in that birth canal, and so their legs are up. When they come out, what do you think they do? Doop, their legs go right back up again. So trying to swaddle a breech, a frank breech, their legs just automatic, because they've been in this position. Does that look comfortable to anybody? No, right? So what are you gonna feel when you do a vag exam with a frank breech? You feel the butthole, right? The butt right there, it's there, okay? All right, then you have complete breech. So this baby got in the great position, nice tight flexion, however, what way? The wrong way, right? So this baby's in the good fetal position, it's just not vertex, and so we can't do anything with that, okay? I will tell you, C, a singling footling breech is one of the scariest night shifts I ever worked in my life. No prenatal care patient came in to triage. I hate triage. I am not an adrenaline junkie. Do not send me to the ER. Just give me yesterday my patient going practically septic was like, I was like, I don't like this. Just give me a calm, smooth environment, okay? I've done this too long. 14 years, I don't want adrenaline anymore. I'm good. So I was working triage, patient came in from Mexico, no prenatal care, ambulance, brought her in. And so have a translator, trying to ask her questions, and she said that she was contracting. I go to put her on the monitor and I go to check her, and there's a foot hanging in her vaginal vault. I go to do a vaginal exam and there's little toes doing this, hanging down in there. Stat section, right? Stat section. I don't want her dilating. I don't want anything coming out of this vagina. I've never had a double footling, but I have had a single footling, which again, both of those, all of these need cesarean deliveries, right? All right, so we already talked a little bit about this, so we want to know what their attitude is, and that is the degree of the flexion. We want good attitude, which means complete flexion in that fetal position, okay? Again, this is just another picture showing you your vertex. You can have your military, your brow, or your face. The face is probably going to be an extremely hard delivery to do, just because look at the way that baby's in. That head is not favorable to come out. All right, so station. This is the relationship of the presenting part of the fetus to the ischial spine. So remember we talked a little bit about this when we were in lab as well. So what are your negative numbers? You're floating, you're loving life, right? That's when they're gonna be ballotable, or you're gonna have ballotment when they're in the negative numbers. What is ballotment? You can go in and something bounces off your fingers, right? Because they're not engaged. Once you have engagement, there's no ballotment. Okay, what is engagement, everyone wants to know? It's at 0 station. 0 station equals engagement. And why? Because it tells us that they've made it into that spine, ischial spine, okay? They are now engaged and they're ready to come out. Does that help? So you have -4 to +4. +4 is on the floor, is what I always like to say. So +4 means they're crowning and they're coming out. There's no other numbers other than delivery, okay? So -4 would tell you they're way sky high, they're just having a good time in there. Plus numbers is we're gonna have a baby. So I say that because a lot of times people think, oh, you're 10 centimeters, it's time to have a baby. Not necessarily, because you also have to look at their station. If they're at 0 station, they have 4 positive numbers. They have to come before they come out. So if they have an epidural or their pain is being managed, we'll have the baby and the contractions do its work for less pushing time, okay? Especially in the first baby that they have. Otherwise, who's ever heard a patient say, I pushed for 7 hours? We've never let anyone push for 7 hours, but that's their birth story. I love when I hear people's birth stories all the time. I love that I was in labor for 96 hours, and I'm like, no, you weren't. No, you were probably an induction. We were trying to get that cervix favorable to start dilating. Nobody's in labor that long, okay? So again, that's why you have realistic expectations. If someone's gonna be induced, we have to let them know your body probably won't make any change for the first 48 hours. You don't get to count that 48 hours. Even though you're in the hospital, that's not part of your labor experience, okay? So we wanna go negative to positive, +4 on the floor. 0 is engagement, which means that baby's in that ischial spine and on its way out the birth canal. So this is just a picture to tell you, basically to show you the progression. So these are the cardinal movements of labor. Again, we want nice, good flexion. The baby, as the baby comes out, you can see the baby's going to do an external rotation, hopefully to the left or the right. And what does that do? That helps us pop those shoulders out to have complete expulsion of the fetus, which then becomes what? A neonate, right? It becomes a neonate. All right, so our primary powers are our uterine contractions. What our uterine contractions do is hopefully they cause effacement, dilatation of the cervix, and moves the baby down, okay? Uterine contractions are involuntary and therefore cannot be controlled by the woman if it's true labor, and we're gonna go through true versus false labor, okay? So what happens is you have your frequency, your duration. What is frequency? The start of one to the start of the next, measured in minutes. Frequency is in minutes. The start of one to the start of the next. Duration is the start of one to the end of one, and that's measured in seconds, okay? All right, so we wanna be looking at this contraction pattern. If they're contracting irregularly every 7 to 9 minutes, do you think we're gonna have a baby? No, we're not gonna have a baby. We need to have them closer together, and we need to have them, again, lasting a good amount of time, okay? So if you're having 30-second contractions, you can't even get 3 pushes in on that, so that's not gonna help us have a baby, okay? However, anytime we look at a contraction pattern, we need to have at least 60 seconds of resting in between each contraction. Why? Why do you think we need a minute in between each contraction? At least a minute.
Cause it's hard.
It's what?
Cause it's hard to begin to rest.
Does mom need to rest?
Yes.
The baby.
Or what is the uterus?
Oh, must,
Anyone ever work out at the gym
yeah,
and you work out too much and then what happens?
you cramp.
You cramp and your muscles hurt, right? This muscle doesn't understand what's going on. So if you're going contraction, 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 what is that muscle gonna do? It's gonna give out, right? It's gonna give out and say, I'm done, I'm pooped, I can't do this, okay? So we have to let our muscles relax, right? So you want a good contraction, relaxation. Contraction, relaxation. You need at least 60 seconds of resting between each contraction. When should mom have pain during contractions? Only during the contraction, right? Should they have pain during the resting tone? No. If they have pain during resting, you gotta start critically thinking. That might be abruptio placentae, that could be a uterine rupture, that could be different things. They should not, it could be an infection. We should not have any pain during the resting time, okay? They should be able just to be in their zen and relax during at least that minute, okay? So again, we need a good contraction pattern, but we also need a nice resting tone, at least 60 seconds in between. What else is happening? Let's think about the physiological aspect of this. So when that contraction is happening, what is going on with that fetus?
Coming down.
Being squished, right? Being squished because that contraction is right here, and what is the purpose of the contraction? To push that baby's head down. So what do you think is happening to the oxygenation of the fetus during this contraction? It's constricting because you have all this pressure, remember? Pressure, and so it's constricting. So why else do we need a resting tone? For oxygenation for the fetus, okay? We need that uterus to relax so everything can flow once again. All right, so your contractions are your primary power. We want good, adequate patterns, and again, at least 60 seconds resting tone in between. If we don't have a good pattern, what are we gonna do? Pitocin. We're gonna give Pitocin to make a contraction pattern how we want it, okay? All right, again, contractions during active labor and latent, which we're gonna talk about that, is effacement and dilatation. That is the purpose of it, okay? So if we have good adequate contractions, but we're not having effacement and dilatation, we know something's wrong somewhere else, right? As long as we have that good pattern of those contractions, okay? Once we get to complete, then those contractions have to work with mom, and mom is the secondary power, and that's the bearing down to get the fetus out, okay? So you'll notice when you're out in labor, in your labor rotations, that the evidence base is open glottis pushing, where you're just making noise and all that, but patients tend to not understand how to do that. So we still, even though it's not recommended anymore, we still do closed glottis pushing. Who's ever heard of or seen someone say, take a breath and hold it for 10 seconds and bear down? That's closed glottis because you're stopping your breathing at that time. We tell them bear down like it's the biggest poop of their life, especially with an epidural because they can't feel anything down there, okay? So your secondary is very important because you don't want mom to push until what? With the contraction, right? Why not in the resting? Because they're resting and you don't have the primary power, right? You have the secondary, but if she's just erratically pushing and pushing and pushing, what is she gonna do? She's gonna get exhausted, right? And then she gives out. I tell moms all the time, they don't have handles. I can't go in there and get the baby out for you. You gotta push this baby out. Now, do we have devices that can help? Yes, but they have to be +3 stations. They can't be 0 up in this area, okay? So, exhaustion is one of the biggest reasons our secondary powers don't work. Their psyche is another big reason. Exhaustion, they went through this process for so long, they just wanted this baby out already. So again, our primary and secondary have to work together. There's many times I've had to get a little, not aggressive, but I've had to grab a patient by the gown and tell them they need to get it together. We need to get it together. We can't be doing all this because if the primary and secondary aren't working together, what's gonna end up happening? C-section, right? C-section. And we have a lot of providers who, unfortunately, jump to C-sections. They're like, let's just go. I gotta go golfing. Let's go. No, I'm just, but definitely. So again, we want to make sure that we're managing these patients effectively, okay? Because if your primary and secondary don't work together, we're never gonna have a vaginal delivery. They have to work together. You don't want the secondary to start until what? Until you have complete cervical dilatation. Because if, let's say mom doesn't have an epidural, she's doing it naturally, right? I always tell students, so it used to be that they were in latent, active, and then transition. They've kind of made ACOG, changed the criteria. But 8 to 10 centimeters, they're batshit crazy. That's when the patient goes batshit crazy. Why do they go bad, especially without an epidural? Why? It hurts the worst at 8 to 10 centimeters, those last 2 centimeters. And so a lot of times without an epidural, mom wants to start bearing down. They cannot do that because you can cause cervical swelling and you go backwards on your dilatation, automatic C-section, okay? So again, managing the patients, keeping them calm, trying to walk them through the whole process. All right, so effacement is the shortening or thinning of the cervix. So everyone has to go from 0 to 100. 0 to 100% is the effacement. So remember when we did our vag exams in lab and you felt the first one and it was like really thick? And then as we went through and did our vag exams, you could feel the baby's head and less cervix. That is the thinning of the cervix, okay? In first-time moms or primates, normally they have to efface before they dilate. In multips, they can do it at the same time because the cervix remembers, oh, I've already done this once. Let me start thinning and dilating together, okay? So effacement is 0 to 100% again, and then dilatation is 1 centimeter to 10 centimeters, okay? So you want, before you start pushing with the patient, you want the most best circumstance is 10, 100, +3, because that tells you what's +4 on the floor. It's crowning, right? So that tells you they're not gonna have a whole lot of effort to push that baby, okay? Again, you wanna make the contractions and your passenger do most of the work. So this again is just a picture to show you before labor, the cervix is not effaced or dilated, and then as it progresses. And what is the prostaglandin we give to help effacement? Cytotec, right? What is the synthetic medication we give for dilatation? Pitocin. So Cytotec is for thinning, Pitocin is for dilatation, okay? All right, positioning. So positioning is always fun. I told you guys already my story about my Tarzan lady, right? Oh, did I tell you guys that story?
No.
Oh my gosh, okay. So, there's a patient, she's a nurse practitioner, she no longer is in this town, but, and her first baby, they didn't listen to her, and she had a birth plan. Anytime someone comes with a birth plan, we always say we prep the OR, because we're going back to the OR, right? Tell your friends, tell your family members, we are trained, let us do our job. Don't come in with this 19-page birth plan, because it's not gonna happen. What is that? Unrealistic expectations, right? So she had a birth plan, it was horrible. And so she told everyone about her horrible birth experience. Whoever hears about good birth experiences? Who hears about horrible birth experiences all the time, right? So she's pregnant with her second baby, and they said, Christy, I need you to special her. You're gonna be one-on-one with her. We will not give you another patient. I'm all about that. I'm like, yes, I will stay in that room all day. We will bond. We will sing Kumbaya together. We will eat bonbons if we can. Like, I will chill with the one patient all day long. It never happens, okay? Even when my sister-in-law gave birth, I clocked in to come into work to help and manage her. I got another patient. And so I was like, well, no, I'm not working extra if I'm here for her. Anyway, so I'm like, okay. So she had a midwife, different midwife. She wanted this perfect experience. And she said to me when I walked in, the only thing I don't want is lithotomy. I don't want to go in the stirrups. Legs in the stirrups is called lithotomy, okay? And it's really proven that it's not the best way to deliver because we're flat on our backs. But again, I was like, okay, no problem. We will do whatever. So no epidural, no pain meds, no nothing. She wants to do it natural, no lithotomy. Sign me up. I will work with you all day long. So she becomes complete. And we're trying every position. We have a squatting bar, so I put the squatting bar on the bed, and she was sitting there, and she's squatting like the people in the fields, you know, deliver, and all this. But every time, she was very stoic, but every time she'd have a contraction, and the first time she would be like, and she'd go, ah! And I'm like, oh my God, like, and I was like, somebody's kidding me right now. This is not happening. And so I'm in the room, again, she's my only patient, so I'm her special nurse, right, where I'm doing this. And so the contraction would stop, and she'd talk to me, and her husband was in there, and I'm like, okay, this is, and so then she'd be like, it's coming on, and I'm like, oh my God. So we did this for an hour and a half, right? I opened the door, because I feel like sharing is caring. Like, if I have to hear Tarzan, everyone on the unit's gonna hear Tarzan. And so people are walking by the room, and I'm like, because I said, when I walked out, I said, if I told you she was doing that, you guys would call me a liar. I'm like, no, everyone, and they could hear it down the hall. Wait till you see the unit, right? And so, and I'm like, this is crazy. So I'm looking at the midwife, she's like, we want her to have best experience. I'm like, okay, I'm not here to judge. So we tried squatting, we tried the birthing ball, we tried everything. An hour and a half in, she was exhausted. And she looked at me and she said, just put me in lithotomy. I'm like, are you sure? She's like, I'm positive. We got her in the stirrups, and she delivered after 2 pushes. It was just, she was exhausted. But she was very happy about the fact, right? She never did it again. So I run into her 3 months later, and I'm walking, and she's like, oh my God, Christy, hi. If they have a good birth experience, they usually remember who you are versus, you know. And I was like, oh my God, but instantly in my head, I'm like, oh. I was like, oh my God, that's all I can think of when I see this lady. So, what position is the best position? Whatever position they want, okay? There's no best position. Now, if you have an epidural, you're pretty limited on positions because you can't do a whole lot, and that's usually why we use the lithotomy, because we have the stirrups that can hold those dead legs, but really any position that they want is the best position, okay? Side lying, we do a lot of side lying where they lay on their side, they lift their leg, and they deliver that way. And why would we do side lying?
Her back.
Because we don't want them to compress the vena cava, right? Birthing ball is good. Birthing ball is really good in the early or latent stage of your labor. And I've put my patients who want to do it natural, or we don't really want to give them a lot of meds early on, like in their dilatation. I'll put them on the birthing ball, and I'll tell them that every time they have a contraction, to sit on the birthing ball and spell the baby's name with their hips on the birthing ball. It takes the distraction away from the pain, but it also helps to get that baby in position to come down that birth canal, okay? So again, anytime you can rotate those hips to help move that baby down. All right, we already talked about supine hypotension. That's when they're flat on their back. We never want them flat on their back because it compresses the vena cava. So even if we do a slight tilt, just a tiny pillow, anything, just so they're not flat on their back. All right, and we already talked a little bit about the psyche as well. So the psychological state or feeling the woman brings to labor, it can be anything possible. You can have fear, happiness. Again, it's all about expectations, right? What are their expectations of the outcome? And again, that brings a major role of what's happening. So many people can play a role with the psyche, and it can change throughout the whole process. So we have to be aware, and we have to be there to support them. All right, take a 5-minute, seriously 5-minute break, and then we'll jump into more.